Hello, everybody. I'm Bernie Eliakis, President and CEO of Cornea. Thank you for participating in today's webinar, which is entitled CTAK, Reshaping Sight for Keratoconus Patients. We're pleased to offer this webinar with two terrific speakers, Dr. David Hardten and Dr. Elizabeth Davis, who together have performed nearly 100 CTAK procedures as of this week. There's been a lot of excitement around CTAK, and we have definitely felt that here at Cornea. We launched in June of this year to offer two surgeons, and just at AAO alone, such excitement where we trained 110 plus surgeons through wet lab work that we did there, and the interest continues to the point where we actually even have well over 200 attendees registered for this webinar. In today's webinar, these fine surgeons will share with you the science behind CTAK's innovative approach to treating keratoconus, pre and post-op surgical pearls, as well as when to cross-link and the reasons why. We'll also take your questions throughout the webinar, so you can submit a question anytime during the webinar using the questions box in the upper right hand of your screen. Click on the plus sign, it will open up a text box for you to write and send your comments or questions. We'll take time at the end of the webinar to answer any further questions posed during our session here tonight. We'll do our best to answer as many we can as possible in the allotted time. So now let me tell you a little bit about our presenters. Dr. David Hardten is a board certified ophthalmologist, co-founder of Minnesota Eye Consultants, specializing in cornea, cataract, and refractive surgery. He leads groundbreaking research as director of the Minnesota Eye Consultants Clinical Research Department, covering topics including cornea transplantation, refractive surgery, and drug therapies. Graduating from University of Kansas, completing his fellowship at University of Minnesota, he's been a pioneer in private practice since 1993 and is a esteemed lecturer and author in the field. Welcome, Dr. Hardten. And Dr. Elizabeth Davis also specializes in cornea, cataract, and refractive surgery. She completed her ophthalmology residency at Massachusetts Eye and Ear Infirmary, Harvard, and did her fellowship training in cornea, external disease, and glaucoma at Minnesota Eye Consultants under the HEED Ophthalmic Foundation Scholarship. Dr. Davis is an attending surgeon and partner at Minnesota Eye Consultants. She is actively involved in FDA clinical studies and serves as an instructor for multiple training courses. Welcome, Dr. Davis.
Thank you.
Okay, so without further ado, I am going to hide behind the scenes here and for Dr. Hardten and Dr. Davis to share their presentation with you. I'll join you again at the first opportunity to read some questions for our audience, and we will be starting with Dr. Hardten.
Well, good. Well, thank you, Bernie, for that great introduction. And as I'm sure those of you that are on this presentation are, we at Minnesota Eye Consultants with Liz Davis and myself and our other corneal surgeons are extremely interested and excited about CTAK. And so we're going to share some of our experience with you, some of our thoughts, and we thank the Cornea team for really pioneering this and bringing this to our fields. As you saw in the last slide, we do have some disclosures. I have some disclosures about it. So keratoconus, when I first started in my residency and fellowship, was a try to get by with a contact lens until you need a corneal transplant, was really the thought process at that point in time. We've had a variety of different other options, such as Intacs and improvements in contact lenses over time, but CTAK, or cornea tissue addition for keratoplasty, is really an amazing step up in our management of keratoconus. So, obviously keratoconus is this progressive thinning and deformation of the cornea. What we've had before are contact lenses and then corneal transplantation. But as those of you that do corneal transplants know, they're really fraught with challenges, especially in a young active population, for issues of irregular stigmatism, trauma, ruptured globes, etc. And we've had Intacs that can improve the shape. We're going to talk a lot about cross-linking because our practice has been active in cross-linking now for about 15 years, and that can stop the progression, but it doesn't improve the shape. And many of these patients, even though contact lenses have improved, really want more time in spectacle correction. So CTAK is what allows us to improve the shape in this group of patients to allow a higher percentage of time in contact lenses or in glasses. And so the advantage of CTAK or cornea tissue addition is that it can be customized to each patient. And we'll talk through the process of how CorneaGen provides us information on customizing it. The tissue is cut with very high precision with a femtosecond laser, and then it's sterilized and has a very good long shelf life. And then we'll talk about the surgical intervention. So we can go to the next slide now. And this is a video now of the procedure. The procedure itself, the femtosecond channels are very similar to what you might be used to with Intacs, but they're a little bit wider. So in general, they're about 2 millimeters in width. So you go from about a 4 millimeter optical zone out to an 8 millimeter optical zone. And then we pre-dissect the channels in general. I'm not sure how critical that is. And then here you see the tissue being slid into the channels, and basically it compresses the cornea in the most bulgy area. It thickens the cornea in that thinnest area, and provides a more regular shape. And in general, we'll do this in patients where we also are going to do cross-linking, whether it's done before, same time, same day, or after. We call it ALKRS in our practice, mainly from the standpoint of trying to help the billing office and our insurance carriers understand that it's a anterior lamellar keratoplasty, but the CTAK is the branded name from CorneaGen, and their customized corneal segments, like I mentioned, are gamma irradiated. There's, I've never seen rejection with this. They're custom cut, and we'll talk about the parameters. And then I do think that cross-linking to try to minimize the chances of progression over time are really important in this group of patients, as well as the other things we do for our keratoconus patients to encourage them not to rub, not to sleep with pressure on their eyes. So let's go on to the next slide. And again, like I mentioned, what we're really trying to do is prevent progression and prevent the need for corneal transplant, whether that's penetrating or anterior lamellar, deep anterior lamellar keratoplasty. This is a patient that I saw right around the start of the COVID pandemic, and for a variety of different reasons. Some of it was insurance, some of it was the fact that he didn't want to go out and about in the world. But you can see the subtraction mapping between the topography 2 years ago and the current, and basically had 8 diopters of change over a 2-year period of time. And now we have a much worse situation. So trying to address these patients in a timely fashion to be able to get them cross-linked and also be able to improve their shape with CTAK is really, really critical. You can go to the next slide. Most of you have heard of or utilized Intacs in the past, and we have stopped using Intacs in our practice, partly because CTAK is just such an amazing advancement over what we had before with Intacs, and part of that is the corneal tissue is now wider, so it provides a more gentle compression of the cornea. It's placed more anterior, so these are placed typically at 200 micron depth rather than the previous 2/3 depth that we used with Intacs. And they're customizable, so you can have you can say I want a 180 degree length, you can say I need a 300 degree length, and I need 200 micron thickness, I need 450, or the thickest I put in is 500 micron thickness, and so they can be very customized, and so that provides a better flattening than we saw with Intacs. And I think probably long term we're going to see better tolerance in the cornea because it's corneal tissue. So channel deposits, segment extrusion from nutritional components anteriorly, I think are going to be a thing of the past that was happening with Intacs, but not necessarily with CTAK. So you can go to the next slide for me. And again, part of what we're trying to do is avoid penetrating or a deep anterior lamellar keratoplasty. The other challenge that I had with Intacs is that we have 6 optometrists in our practice that do complex contact lens fits, and they hated fitting contact lenses after Intacs. And what I would tell the patient is like you've got this hard piece of plastic in your cornea and you're trying to fit the contact lens over it. So now you have a gentle girdle over the cornea or inside the cornea, pulling back on the tissue, but the rises and falls that we see with the corneal curvature are less. And these patients are no more difficult to fit in a scleral lens than what they were with their keratoconus. In fact, probably easier because now that tissue has been pulled back and there's less bulging. This topography shows you what I'm going to walk you through on a few case examples where the before and after pictures of the curvature and the topography with a shape subtraction mapping. This happens to be on the Pentacam. But you can see in the middle picture the pre-curvatures with topographies in the 50-52 range. And then you can see that it flattens post-operatively after the placement of the CTAK tissue and significant improvement in the corneal shape. I've got the numbers there too for the uncorrected and best corrected visions, but post-operatively they've gone from or down to 20/40 vision compared to 22/50 to start with. And I'll walk you through some examples. And obviously, those that have milder disease, they may start out with 20/40 or 20/50, and the goal is to get them improved. The ones that are severely irregular still can improve quite a bit, and obviously we'll still see best in a contact lens. So that's a big advantage of CTAK, is that they can still get into a scleral lens post-operative. Actually, many of our patients wear soft lenses too. So you can go on to the next slide for me. So what about cross-linking? Where does that fit in? Part of some of the old data with Intacs suggested that it also stopped progression. And I think probably the reason that Intacs stopped progression is you now have a hard piece of plastic in the cornea. It hurts if you rub your eye or if you sleep with pressure on it. And so, a lot of the mechanical components are important in causing some of the progression. But cross-linking now has become a very accepted method of stopping or slowing down the progression in keratoconus. And so I feel very strongly, our practice feels very strongly about using cross-linking, and that, like I mentioned, that can be done either before CTAK or at the same time, same day, or afterwards. But getting these patients cross-linked and then encouraging them to not to rub and the other mechanical factors, I think is really, really important. And as most of you know, just the riboflavin ultraviolet light increase that collagen strength, and this has been around now. This article in AJO was back in 2003, so over 20 years ago. You can go to the next slide. So it's the cross-linking. As you know, you load the cornea with riboflavin. The only approved system right now is the Avedro or Glaukos system with Photrexa. We use a soaking device to try to help us get the medicine in a little bit quicker. And then there's 30 minutes of light delivery. And there's obviously several other trials in place to try to speed up that process, but this has been well tested over time. And like I said, for the most part, I will do my ALKRS or CTAK, then go ahead and cross-link on the same day, mainly for patient convenience. But you certainly can do that at a separate time. We'll talk a little bit about some of the barriers to trying to do it at the same time if you have your systems or places in different locations. So I don't think there's anything critical to necessarily doing it in any specific order. You can go to the next slide then for me. So the other technique that we've talked about with keratoconus is lamellar or penetrating keratoplasty for those patients that just absolutely, there's no way that even if you improve the shape 20 to 30% with CTAK that you're going to get them into a contact lens. But really, we're trying to identify these patients early enough that they don't need corneal transplant. In our practice, mostly if we do a transplant, we'll try to do lamellar. Of course, as you know, there's probably a 5 to 10, 15% chance of conversion to penetrating, and I think if the peripheral cornea is good enough, then femtosecond keratoplasty is helpful from creating a stronger wound. So you can go on to the next slide. So the diagnosis of keratoconus, now that we have cross-linking, it's much more important to diagnose these patients early to try to prevent progression. And I'm sure that many of you on here are, see patients. The question is this keratoconus or not? For example, this is a patient that had some asymmetric astigmatism, so was referred to me. And I looked and I thought, well, I'm not sure, is this really keratoconus or not? They're 11, they're young, they're at the age where there's significant risk of progression, but the topography didn't really look super abnormal to me. And so looking at this over time is extremely helpful. So I chose to follow this patient at 6-month intervals. I did repeat topography, subtraction mapping, and so far this patient has not changed over several iterations of these 6-month exams. And so this is just a patient that probably has asymmetric curvature, and so I label this as keratoconus suspect. But what you don't want to do is turn this patient loose and 5 years later have them come back and have significant progression, because improving their shape and doing cross-linking at the earliest time that you believe that they're going to have progression is super important in this group of patient. And subtraction mapping has really been a godsend for us in following this group of patients. So you can go on to the next slide. Now, this is another example. This one's a 14-year-old that had evidently had a normal eye exam 2 years ago and came in to see me. And this patient definitely has keratoconus. So they have inferior steepening, they've got thinning, they've got back elevation on their regional pachymetry and tomographic mapping. And so this patient, I don't even believe needs to be tracked and followed to see if they have more progression, because they've had progression in the past. And so in this patient here, I chose to go ahead and do cross-linking and CTAK in this patient because they're already abnormal. The youngest patient that we've done so far with CTAK has been 12. The patient's actually tolerated very well. And so I think it's something where if the shape is abnormal enough that it's tough to get correction in glasses, that you're concerned about progression, then CTAK plus cross-linking really makes sense for them. You can go on to the next slide. So where does Intacs fit in? And as I mentioned, I've stopped doing Intacs, and our other corneal surgeons in our practice have. And yet we actually obtained some pretty good results with Intacs in the past. And this is a patient that had some improvement in the shape with Intacs, but they found it difficult to wear contact lenses. They had channel deposits. And as I mentioned, in a group fashion, it was not very possible to titrate effect. And then, like I said, contact lenses were not impossible, but very difficult to fit. And so those issues have really resolved themselves with the addition of CTAK. And so I applaud Cornea and their team and for really pioneering this and bringing it to where it's very usable for us in the United States. I'd done some hand cut CARES tissue, very similar to what Susan Jacobs had talked about outside the US, but that tissue, difficult to work with, difficult to customize. And I kind of like it when somebody else does some of my hard work for me. And so having them help me with the planning, but also provide me with tissue that is, exactly 300 microns thick, is exactly 240 degrees in length, and I know that I'm supposed to place it 2.4 millimeters from the center. Super helpful compared to the hand cut tissue. And I have a couple patients that have hand cut CARES tissue in one eye, CTAK tissue in the other eye, and I'm not sure they can tell the difference. But when I look at them at the slit lamp, I'd rather send them back to the referring optometrist or ophthalmologist with the CTAK tissue in place. You can go to the next slide for me. So we'll walk through a few cases, and the fun thing about this group of patients is they're all different, and so you're trying to figure out, what are my goals, what are my expectations for this patient, how can I achieve the best result, and honestly, if they're mild enough in that eye that they can see really well in glasses, they can wear a regular soft contact lens. I'll usually just do cross-linking to try to prevent progression. But unfortunately, we still see patients at the stage where they've lost best corrected spectacle acuity. They're struggling in glasses. They have anisometropia, so they're asymmetric, and so really. I'm not sure what the percentage is, but it's probably over 75% of the patients now I see with keratoconus, they get both CTAK and cross-linking. I'm hoping that number of patients or percentage of patients continues to go down as we see patients in earlier stages, but still, even in our referral area where we've been doing cross-linking for 15 years, we have patients coming in at the stage of keratoconus you see here in this topography, and so really, for the foreseeable future, CTAK is going to be an important addition to your practice and to what you do for your patients. So this guy is 21. He has it's worse in the left eye than in the right eye, but he has keratoconus in both eyes, as you can see on the Zeiss-Humphrey axial type topography. And I've chosen to put the left eye pentacam information up there because that's what we're going to address first. I normally will do these patients maybe a couple months apart so that they can get into their correction on their worst eye before we do their second eye. Certainly the recovery is reasonable enough. You could do both eyes at the same time, but most of these patients, especially if they're asymmetric, prefer to be able to function with one while they're dealing with the recovery in the other one. So here you see the uncorrected vision at 2250, best corrected 2040, and then 3 months after CTAK and cross-linking, uncorrected at 2040, best corrected at 2020, and then scleral lens 2020 vision. So as you can see, it's not a refractive surgery. It's not like, okay, we're going to dial in a result and you're going to have total uncorrected vision, but in comparison, how they function at home when they're not wearing their scleral lens, when they're getting up, they're getting breakfast, they're getting around the house in the morning, just amazingly different for that group of patients. You can go to the next slide. So in this next slide, you see the subtraction mapping in that upper right-hand corner. So you see quite a bit of improvement in the patient. You go on to the next slide for me. And here you see the planning software that's given to you. So basically what you do is you send the Pentacam raw data to CorneaGen, and they'll come up with a suggested plan and a couple of alternatives. And what you're doing in general is encompassing the cone and compressing the cone. And the location or distance from the center is important. So for this example, 2.3 millimeters intertemporal to center. You've got a segment that's 260 degrees in length, 300 microns in thickness. And as you go through various different examples of your own, you'll get a sense for what you should be doing. But the software, we've really trusted that software in the vast majority of cases. Plus that CorneaGen has a team of people that are there locally, but also they've got resources through Peter Hirsch and Stephen Greenstein that have done this for quite a while that can help in those cases that are sort of questionable as far as what should the location, orientation, and thicknesses be, that are there as a resource also to help you as you go along. And go to the next slide for me. Here's another case. A little bit older patient. You see the curvatures here, very significant inferior steepening, almost 8 diopters of astigmatism. And at 3 months, improvement in the regularity. Uncorrected vision really didn't change much, but the best corrected vision and amount of astigmatism changed quite a bit. If you go on to the next slide, I'll show you the curvature differences. You see in the middle, the 3-month curvatures where there's significant improvement. Again, expectation management, these are not normal eyes. You can't make them normal, so there's another reason to try to stop progression at the earliest stages, but they're very functional with that quality of vision post-operatively. And go to the next slide for me now. Here's the plan in this specific patient. Most of our cones that we see in Minnesota are infratemporal cones. We have some central cones that basically are about a 330 micron circumferential segment, but here another infratemporal cone. So you can go to the next slide for me now too. Here's another one, extremely advanced, 27-year-old, and this is more of a central cone. Very myopic, better best corrected vision because of the fact that it's a central cone. And 3 months post-operatively, improvement in uncorrected, best corrected vision, and they're now working on scleral contact lens fit. So you can go to the next slide for me. And then here you see this one is a 330-degree length segment. You want about 15 degrees on either side of the incision so that there's less chance of epithelial ingrowth. So you basically stay away from directly next to the incision as we work through the surgical technique. And again, getting fit for scleral contact lenses. And go to the next slide for me. And here's what that patient looks like post-operatively. And again, the curvature in this group of patients is just amazing improvements in the corneal curvature post-operatively. You can go to the next one now, it's fine. And then you can go on to the next slide here. I'll probably just skip this case for time, but another very severe case with significant improvement with a 300-degree length segment. You go on to the next slide. And here's the subtraction mapping. You see almost 20 diopters of corneal flattening in the center for this specific patient. And you can go on to the next slide for me. So I'm going to share some of our data that Liz and I have put together. We're presenting this data at ASCRS coming up in the spring, and our fellows and one of my scribes has really helped us put this together. You can go to the next slide. So you see an improvement on average of uncorrected vision. We have 78 patients that have at least 3-month data. So that's what's being presented here. Again, these are not, it's not like they're going all to 20/20, but significant improvements in uncorrected vision. The worse they start, the more improvement you see. The less severe they are to start, the less improvement you see, as you would expect, but still significant improvements in uncorrected vision. You can go to the next slide. Significant improvements in best corrected vision. And again, most of these patients can still tolerate a contact lens extremely well. Some of them have never been fit before. Some of them will go back in to their same contact lens, usually starting around a month after the surgery, and then get refit about 6 to 9 months after their surgery, because oftentimes there's enough flattening that they'll get bubble formation or murky tear film in the space between their scleral contact lens and their cornea. And go to the next slide for me. Spherical equivalence reduced significantly. On average, we saw about 3 diopters of flattening, about 2 diopters of flattening from -3 pre-op to -1 at the 6-month mark. And then go to the next slide. We looked at, you can go on to the next one for me now. Mean keratometry also improved significantly, about 4 diopters. And then you can go to the next slide for me. And then the mean keratometry improved significantly. You can go on to the next one there for me. We looked at a variety of different keratoconus indexes. Most of them also improved. This just happens to be the center keratoconus index, but we've looked at a variety of the different topographic and tomography indexes. You can go to the next slide for me. So with that, I'm going to bring Liz Davis back on, and I'm going to let her talk about patient selection and counseling. After we maybe, Bernie, if we want to take a couple minutes here, if there's some questions that need to be answered, or maybe if Liz has some comments on the first half of the presentation, I can have her give those now. Otherwise, we can certainly wait and save questions for the very end once Liz goes through some of the other points that I think are really important from the CTAK standpoint.
We do have a few questions, and it might be a good time to ask some of these. We have 4 questions thus far. First one is a question, FDA approval, question mark. I can answer it from at least from the tissue processing side. I'm not sure if they're talking about the tissue processing side or from the surgeon clinical side of doing this, but obviously as an eye bank, we're FDA regulated and EBA accredited. So this is under the same purview as we would do any tissue preparation. The sterilization and gamma radiation procedure we do is reviewed by FDA as well. We do it with scleral tissue and other clear cornea tissue for glaucoma purposes. So that piece is all under purview of FDA. Anything from the surgical side from FDA oversight?
Well, in our practice, we considered this a lamellar transplant, and so lamellar transplants have been around for a long time, and this is I don't know, an altered way or a different way that I think is a big step of improvement, and so we consider it something where it's currently standard of care in our practice for sure.
Next question, and I think you touched on this a bit in your slides, Dr. Hardten, but I've never been impressed with Intacs outcomes. So how does CTAK outcomes differ from Intacs?
So it depends on what it takes to impress you. So again, as I mentioned before, if you're looking for somebody to go from -16 +8 and 2200 best corrected, and what would impress you is 20/20 uncorrected, you won't be impressed. But it's better than Intacs. It's safer than, in my opinion, it's safer than a corneal transplant, less risky in the long run, and the patients function extremely well. And so, and the biggest advantage, as I mentioned, is that with Intacs, I struggled with trying to get them into a contact lens. And so our contact lens fitters really didn't like that. And so I think it's more impressive, but again, it kind of depends on what it takes to impress you.
Next question, more of a surgical question. What is the smallest thickness available for this tissue? Of course, I can answer that a little bit, that we can make it really kind of any thickness depending on what the map would indicate and the software indicates, but maybe what has been some of the thinner insertion tissue that you have both used.
Yeah, Liz, I don't know what you've used. 150, I think, is about the thinnest I've used. 150 degrees, something like that. I think if you get below that, you're probably cross-linking only and not necessarily gaining a whole lot. Liz, your thoughts on that?
Yeah, I haven't had anything that thin. I would think mine was probably in the 200 range, but yeah, I would think, yeah, because the thickness correlates to how much flattening you're trying to achieve. So if it's super thin, then you're obviously, that's not a very steep cornea. So, they might be better served with, I mean, that patient like that maybe just will get fit, in a contact lens without doing anything.
Mm-hmm. Next question, can CTAK be used to improve astigmatism in high cylinder keratoconus suspects? For instance, in the map of the 11-year-old, if he proves stability. He improves stability, maybe that's what he's saying there.
I haven't personally done that. In a patient like that, when they reach the level of maturity, if they have 4 or 5 diopters of astigmatism and they're not progressing, they have thickness such that you can, that you could take a little bit of tissue away. I guess you probably could, but I'd probably lean more towards PRK or LASIK in that patient if I didn't think they were going to progress over time. So when do you decide it's keratoconus versus suspect? When do you stop calling them suspect? That, you know, that patient 10 years from now, it's the same. I'm not sure I'd even think of them as suspect anymore. But I don't know, Liz, what your thoughts are on that.
Yeah, and I guess in that situation, you'd probably have to cut your segment so that you were flattening, you know, just on either side, because as it comes, you know, it is one piece. And so you're going to get, wherever it is, you're going to get flattening in that area. That's why I think, like, for example, in the keratoconus patients, the ones that probably do the best are the ones with asymmetric steepening or inferior steepening. As you saw in the more severe cases with those central cones, you have that 330-degree segment, but it's not as much addressing the astigmatism because it's just circumferentially flattening it, but then you don't, I mean, if at some point Cornea Gen can make it differentially thick, or you split it in two or something like that, then maybe so. But yeah, so you'd probably have to do something like what Intacs do, having semicircular, you know, or you know, even smaller segments on either side to treat it.
Very good. Well, more questions are coming in, which is great, but we will continue on to part 2 here, and Dr. Davis.
All right, great. So I'm going to talk a little bit about, you know, patient selection, which patients are good candidates for CTAK, and how do you talk to patients about CTAK. So next slide. So your ideal candidate obviously is going to be a patient with keratoconus. Patients with pellucid don't do very well with this, simply because, as you'll see here, their kind of steepening and bulging is too far peripheral, at least for the way they're constructed right now. So what you want is the maximum steepening and the thinnest part of the cornea to be within the 6 millimeter optical zone. And basically Kmax probably somewhere between 50 and 80 diopters, and you don't want to go too much thinner than 300 microns for the thinnest part. Obviously, typically their best corrected acuity is going to be worse than 20/20. Otherwise, why are you doing it? And that they have a central or paracentral cone within the central 3 to 5 millimeters. Certainly don't want, or at least visually significant scarring in the visual axis, because this isn't going to address that. Few caveats. As Dave alluded to, I think previously, or maybe that was an outside conversation, but if you're doing this for post-LASIK ectasia, you might want to do an anterior segment OCT to see where the flap is, how thick it is, so that your channel will go deeper than that. And then when you do a dissection, make certain you're in the channel plane and not dissecting through the flap interface. On the other hand, if you're doing it after Intacs, you remove some Intacs. Maybe I have a fellow that I'm going to be removing his Intacs because they are eroding in an area, and then we'll wait, and then we'll do CTAK. And so in that situation, since Intacs are typically placed at 70% depth, you probably want to go somewhat shallower. You can go next slide. So how to talk to these patients? You would kind of describe it as like a belt or like Spanx. So, you know, you tell them that with keratoconus, your cornea is too thin and weak, and so that leads to bulging and therefore vision problems. And so CTAK is kind of like Spanx for your cornea. You're putting in a thin layer of donor tissue, and it's supportive, and it's going to help the cornea hold its shape better. And it gives extra strength and structure to the cornea in that area. But as Dave alluded to, you know, two important things. One, you want to let them know this doesn't stop progression, so you also need something done for that, and that's collagen cross-linking. And this isn't going to get you out of your glasses and contacts. It is just going to hopefully make you see better with your glasses, make your contacts fit better, and have better corrected acuity. Next slide. And next slide. So the procedure. So basically, you have your pentacam and you're going to send the raw data, which is called a U12 file, to Jason Brill or Mitch O'Donnell at Cornea Gen, and then they will construct the plan. And when you schedule your surgery, it should be at least 6 weeks out, because that's about how much time is needed for tissue prep time. You could go to next slide. So this is what you're going to get back from Cornea Gen. There's some additional things typed over it, but if you look on the left-hand side, Jason will send you, the recommended tissue construction, and then you have a couple options, and there the options are thicker segments. So if you wanted for some reason more flattening or less flattening, maybe, you don't want to create too much anisometropia with the other eye, or you think you want to flatten it a lot more, you have those options. For right now, the inner diameter is either going to be 4 millimeters or 4.5 millimeters, and then the outer diameter is 8. Cornea Gen's working on a 5 millimeter inner diameter, and basically it'll be 4.5 if your maximal steepening is more peripheral, so maybe more of an ectasia case. And basically what it's doing is wrapping around the base of the cone. And typically the segment extends several degrees beyond the breadth of the cone on either side. And you can also see in that right-hand photo, they're going to tell you how to offset from the center of the pupil. So you'll be given those 3 numbers in green for temporal, inferior, and infratemporal. And that'll be where you make your 3 marks and then use an optical zone marker to connect those 3 dots. You can go to the next slide. So the equipment that you're going to need, you do need to have the pentacam with the iris camera. They are working on an option with the Zemer, and then those are the compatible lasers. Unfortunately, you can't use the J&J Catalyst, the Lensar, or Excimer lasers. And then you need some instruments. You can go to the next slide. And Corza Medical provides a full set of instruments. So there are 2-point markers. So that's for marking your offset, and they come from 1 to 4 millimeters, and it's a 1/4 millimeter increment on either side. And then you've got the optical zone markers. Currently, you're just going to need 4 and 4.5 millimeters. And then you've got the channel dissectors, just like if you did Intacs, you had the to the right and to the left dissector for the channel. And then curved forceps for grasping the tissue to insert it into your channel. There's a manipulator, and then I call this the milker. It's an applinator that helps you kind of milk the tissue along through the channel, particularly when you have an extra long segment to get it all the way through. Next slide. So basically what you're going to do in the procedures, so this is, so you're going to start in the laser center, and some people have to do it, break up the procedure. They might have their femtosecond laser in one building, and then OR is going to be someplace else, and cross-linking is going to be someplace else, and that's okay. And there are even surgeons who will make the channels one day, and then a couple days later do the insertion in the OR, because the channel will still be there. You'll just open it in the OR. And then maybe cross-link in a different facility. So you're first going to mark the center of the pupil. And then you're going to make those markings, the inferior, if it is an infratemporal steepening, you're going to have inferior, infratemporal, and temporal. And then you'll connect those with your optical zone marker. And then you'll move under the femtosecond laser. And now you're going to center, rather than on the pupil, on your OZ mark. You'll make the channel, it's quick. And then you'll use your channel dissectors to open it up. And then you'll, at some point, go to the OR. You can insert it into the channel in the laser suite. You just may have more of a difficult time getting reimbursement for the tissue. But each of us have done that in particular cases, and then smooth the inlay. You can go to the next slide. So here's showing you using the markers to marking the offset and then the optical zone marker, and then using the femtosecond laser and then centering again on your optical zone marking, not the pupil. Next slide. And then you can play this, and then you're just going to insert, and these are those curved forceps, and insert the tissue into the channel. And it goes pretty easy. Obviously, if it's a much longer segment like the 330, you're probably going to need to insert it and then come around the other side and pull it. And then that's the applinator that because it does tend to get a little bit bunched up in sections. And so it'll appear much shorter than what it was supposed to be. And that's just because it's bunched up. And so then you just milk it around with the applinator. And you don't need to put a stitch in. We used to put stitches in for Intacs, but you don't need to in this scenario. And this is all under topical. We do give them a little IV sedation, but again, also have done the whole thing in the laser suite with, maybe a Valium. So it's really not uncomfortable at all. Okay, you can go to the next slide. You can advance to the next slide. Okay, so billing and coding. So for the diagnosis, you've got progressive keratoconus, irregular astigmatism. That's your coding for that. And you certainly want to note in your chart that the patient has difficulty with glasses and or contact lenses. And then those are the billing codes for lamellar keratoplasty or CTAK, and then there's the code for tissue. And then if you are, doing a procedure, making your channel in the laser suite and then moving to the OR, the XE modifier allows you to bill for the two separate procedures in different locations. And then there's cross-linking. So, when should you do cross-linking? Of course, this is early, so we don't have data specifically for CTAK. So what does the literature tell us theoretically right now? So next slide. So obviously you can do it either the same day. It's going to be more convenient for the patient, ensure that they do it. Later, then the patient's not in your facility for as long. And obviously some of you have to do it that way if it's two different facilities. And we also have done CTAK on some patients that have already been cross-linked. Evidence shows you still do get a definite benefit, so you shouldn't shy away from that. You just may get a lesser effect. So next slide. So, okay, so what does the data show? If we look at Intacs, a study by Greenstein and Hirsch, they compare doing simultaneous Intacs and cross-linking to Intacs and then cross-linking 3 months later, and found that there was no difference in outcomes. So you've got at least maybe from that data, a 3-month safety zone. Okay, next slide. So, then the question is, because some people say, I like to wait for stability and then cross-link. So, well, what is the trajectory of the shape and visual change with CTAK? Well, it's really quick. You get your biggest effect, even, from this data, and this again is Greenstein and Hirsch, is there's a big effect even in the first week. And then a little bit of, change and noise or, stability. And this is, they didn't do cross-linking in this study. And so this is out to 6 months. So, basically, if you're, you could say, well, if you want to wait until you've got this change, you might think, oh, hey, I could wait, a week and that should be adequate. I'll go to the next slide. But, cross-linking doesn't, oh, you can go previous slide. Cross-linking, just when you do it, isn't instantaneous. You don't, apply cross-linking and then it cures and you're done. The changes occur over time. And so this is a study looking at the morphologic and functional changes. And they do correlate. So what happens over time is the epithelium gets initially at the first month, it's thinned, and then by 3 months, it's thicker, and then you have stability 3 to 6 months. The stromal density takes some time to increase, so you get increased keratocyte density, but that takes 3 months. So, when you do it is not going to be when you get your maximal effect from cross-linking. So even if you do cross-linking the day of the procedure, the day of CTAK, you're going to be fine theoretically, because really its maximal effect isn't going to kick in until 3 months. So you're still going to have flexibility of the cornea to undergo any shape change that CTAK induced. And you can, I was talking with Brandon Ayers and he said, I'd even be comfortable doing cross-linking a week or two before. And I think, at least theoretically, that probably makes sense too. Maybe not 3 months before, but a week or two before seems to make sense. You can go to the next slide. And this just points out that, likely, you can still do CTAK after cross-linking, but as data show with Intacs are more effective when they're implanted before rather than after cross-linking, suggesting that the enhanced rigidity of the cornea from cross-linking dampens any change. Next slide. Now, on the other hand, let's say you're going to do CTAK, and then you're going to do PRK for any residual refractive error. Well, Canelopoulos showed that you get superior results when you do PRK and cross-linking simultaneously compared to when you do cross-linking and then you do PRK. And maybe it's because when you do your PRK afterward, you're removing some of the cross-linked tissue. You also tend to get more haze when you do it in that order. So if you intend to do PRK after CTAK, it might be best to delay your cross-linking until when you think they're refractively stable. Next slide. So basically, thoughts on what's available. You likely could do cross-linking within the first 3 to 6 months with no difference in outcomes. And since the greatest change, corneal change, occurs within the first week and cross-linking takes 3 to 6 months to mature, it seems unlikely that early cross-linking is going to reduce your effectiveness. And so therefore, it really doesn't seem that there's a time point after CTAK that's too early to perform cross-linking. But obviously, we need specific studies. The next slide. And then this is our drop regimen. It's the same as cross-linking, antibiotics 4 times a day until gone, steroid taper, NSAID, Mura 128 ointment, vitamin C for 3 months, pain medicine. That's more for the cross-linking than for the CTAK for the pain medicine. Next slide. So, so finally, what are our thoughts on criteria? There really aren't any hard cutoffs. And so, the examination and discussion with the patient, how they're doing is the most important thing. So like Dave showed, if you got a young patient who's got changing astigmatism, not necessarily inferior steepening, you should follow them, do yearly tomographies, counsel them on eye rubbing and sleeping and those sorts of things. Likewise, if you have the older patient, older than 50, kind of outside the range of progression, and they haven't progressed, and they're doing well with their glasses and contact lenses, again, you can just watch them and do yearly topography. You can go to next slide. If they're doing under 50 and they're doing well, then with their glasses or contacts, then cross-link alone. If they're not, it's uncomfortable, they don't get good vision with correction, difficulty manipulating or a strong aversion, then those patients are good candidates for CTAK and cross-linking. And then in those really advanced cases where you've got a scar or cornea is too thin to place the segment, then a DALK or PK makes sense. And I think, next slide. So basically, I think, CTAK has been a great addition to our options for keratoconus management. You get improvement in the shape, uncorrected vision, best corrected vision. Patients can still wear scleral contact lenses and should be counseled that they likely still will need them. And then important to do cross-linking afterward to stop progression. And I think that's it. So.
Excellent. Thank you, Dr. Davis. Very good. I know we have a couple minutes here and we had a lot more questions come in, so we'll go a little bit longer here. Some of these questions are repetitive with each other. The big one coming up is, which we asked about 3-4 different times, what is the thinnest pachymetry a patient can have to still do CTAK safely?
Well, so Cornea Gen says 300, but I did have a fellow who in the thinnest area, so maybe this was probably a bit risky. I think he was 250 or maybe even a little bit less in one area, but I tried to avoid that area. But maybe Dave, you've got some thin ones.
Yeah, I mean, I think so you're trying to put this at 200 micron depth. I think if you went more anterior than 200, just because of thickness, and the regional pachymetry on the pentacam is pretty accurate, but you're going to want to, especially in those cases where they're pretty thin, you're going to want to look at the sections where you're going to place the tissue. Most of those, like Liz had mentioned, you're doing you're not going into the center quite as much, so you're using a 4.5 millimeter central component of it. I think the very center thickness is not as critical. It's really that thickness in the region that you're going to place the tissue, and then also too the a lot of patients, when they get to 150, 200 microns in the center, they've got significant scarring. I do have one patient where they had a lot of scarring, but their occupation and just their general lifestyle is such that I really wanted to try to avoid a transplant. And so he was probably, 250 thick in the center, but he was thick enough in the mid periphery that I did a 330 micron or a 330 degree segment at a 4.5 to an 8 millimeter zone, and he did just fine. So I think that it's, unfortunately, it's all clinical judgment, but your backup is a corneal transplant anyway. And so, I think from my perspective, if this didn't work, you perforated, you didn't get a good result, you're still going on to what you would have done anyway before we had CTAK.
Right. Question on as far as placement of the segment, what % corneal depth do you usually choose to implant CTAK?
So Liz mentioned this, but I'll kind of briefly say that the 200 micron really has worked well in normal, or not normal, these aren't normal cornea, but in keratoconus, naturally occurring keratoconus. Post LASIK ectasia, you want to be careful about the flap. So as Liz mentioned, maybe OCT analysis, maybe looking back at old records, but most of these have thinned out even since the old information. So we have one where they have lots of stitches in their cornea after post LASIK, and it was done at a 300 micron depth. So that group of patients is just more challenging, and you'll want to go deeper. But it's different than Intacs, where it was 78, 67% depth, 70 or 67% depth. You're looking at trying to figure out how anterior can you go without creating problems with the previous flap, et cetera.
A little bit different question here. Have you tried a custom laser procedure to improve corneal regularity plus cross-linking after?
Liz, I don't know if you have any, but I've got one patient where I've done PRK. They had cross-linking already because I did that with their ALK-RS. And so I've done PRK. My preference historically has been to wait about 6 months after I do cross-linking before I'll do PRK, because as Liz mentioned, the data, if you do it, not at the same time, but fairly early afterwards, they tend to develop a lot more haze. So I've got a patient, the challenge in that group of patients is you're trying to decide, so they've got strong, thin tissue, and what happens if you make them strong individually but thinner, and so they run some risk of progression. So I've done very few. Most of these people I try to talk back into a contact lens or glasses.
Question here that's somewhat an obvious one. I know the answer, but it'd be great since you all have done about 100 of these, and probably the biggest group of any center. Any donor tissue rejection in these cases?
I have no.
Yep. And in about the 350 plus that we've done from last year, and of course into this year, there has not been a case of rejection yet. Let's see here. A couple of similar themes of questions also. See, reshaping the cornea or shaping the cornea with PTK. Today's nomogram is only based on CTAK graft thickness and length? Question.
And I guess width, a little, the from 4 to 8 or 4.5 to 8, and thickness and length.
And location of placement too. So the location of placement, more peripheral, more central, is also a factor. And so what CorneaGen does, as you saw in some of the plans that Liz had up there, basically there's 3 different, sort of lengths and thicknesses so that you can look to see what some other options are. And then certainly if it's something where you think, I'm not quite sure that makes sense to me, I want to know about it, that's where the resources of the team that CorneaGen and the CTAK team have really put together for you are helpful to talk it out, to try to figure out is the computer generated plan. They're all looked over by one of the CorneaGen people before they're sent out to you. So they're not just like, it's not like you've got an on-screen planner. And so you've got some backup there. I've found them very useful. There's been a couple of them where and maybe it's just me wanting to tweak something that I've decided to do it, but it really is up to you in the end what you end up taking from them. But I don't know, Liz, how often do you switch up the plan compared to what you're given?
Not much. I think most often, maybe on one occasion, I pick the thicker segment, but most often I go with what's recommended.
Instrument question here. I can't remember which video it was or which of you that showed it, but could you tell us the name of the brand of the curved titanium forceps you used in the insertion? Not sure whose video.
Yeah, it was from the whole Corsa Medical set. It was Gillis. Maybe it was Hirsch Gillis curve forceps.
It was with the Corsa, though, with the Corsa.
Yeah, it was with the whole set. Yeah, you can also buy through Corsa Medical. You don't have to buy the whole set. You can buy those instruments individually.
What type of cross-linking with Avedro do you recommend? Accelerated or traditional Dresden protocol post CTAK?
There's only one available right now, but if you're in one of the investigational trials, there's a couple of epithelium accelerated trials going on right now. So I mean, we've participated in 5 different clinical trials and over 15 years, and so it just seems like it all works so far. So whatever's out there.
After 100+ cases at MEC, what sort of changes have you made in how you talk with patients, logistics, billing, surgical approach, any of the above? Any particular modifications from, say, your first dozen cases to your more recent ones?
I think until I got some experience with it, I was probably a little more tentative in who I used it in. So my first cases were quite severe because I was thinking of it more as, a lamellar graft. And then when I saw the improvement and how, easy it was and a lot less dangerous for the patient, I've become more liberal in which patients I will do it in. And I think it's also just important to, have that conversation with the patient about, how they're doing in their contacts, or, I had one patient early or newly diagnosed with keratoconus. It clearly wasn't early. And talking with him, and there was just no way he was going to wear contact lenses of any sort. So in just the hopes of improving his best corrected vision with glasses, that was really our only option, because he didn't want to stay the way he was, which is what would have happened if I just did cross-linking. So I feel like I've become more liberal in who I do it in.
Mm-hmm. Let's do just a couple more questions. I know we're over time and there's a lot more that come in. So we will answer these out to you all, especially if you have identified yourself. But do you mark the offset from the pupil center in upright position or supine? If supine, do you mark meridians in upright position?
I do it lying down when they're under the laser.
I do too. I think it's we have our femtosecond and our excimer lasers right next to each other, like probably most of the people that do refractive surgery do. And so on the excimer laser, there's a good, flashing fixation light. So then, and there's the challenge under the femtosecond is there's a lot of parallax that can occur. And so we have them fixate on the fixation light. We measure the distance from center as you saw on the plans, and then use an optical zone marker to try to do our best approximation of where that should be centered, and then move them over to the femtosecond laser and try to carefully control the parallax. I don't know that there's really any significant ability or improvement by setting them up. And then the challenge is fixation lights on all of our instruments, like a slit lamp, are challenging. So I much prefer to do it laying down, but you do have to be very careful about parallax. And also too, once you mark, sometimes your mark isn't exactly what you want. So then you have to remember, my mark is a little superior or temporal or nasal to where I really wanted it, so that you can adjust it when you do your femtosecond centration.
Good. Any tips on whether you choose a thicker CTAK if the patient has already been cross-linked months ago to achieve more effect?
I think it's probably the same, but that, you know, this is so new. We're going to learn all sorts of great information, you know, by having all you guys go out there and do your first 100, 200, 500 cases. So I, you know, a lot of those nuances, I think, you know, like Liz mentioned, we really don't know the answers to some of this, but even where we are is amazingly more helpful for me and my patients than it was 3 years ago or 4 years ago.
Mm-hmm. Have you done cataract surgery after CTAK? Any implications for cataract surgery?
I've done one. So I had, one of the other surgeons in our practice, one of our fellows, talked to a patient and said, you know, maybe we can, you know, he was kind of like Liz mentioned, you know, there's some of these patients that just are not going to wear a contact lens. So he had done the CTAK in a patient that did cataract really, really well. He's in a scleral contact lens. His shape is probably better than it, you know, would have been if he hadn't had the CTAK, and that guy's really, really happy. But again, it's the expectations. If, you know, if it were your you know, your patient that comes in wanting a presbyopic IOL, they wouldn't be happy. But this guy's super happy with his results. But it's not, you know, he's certainly not 20/20 without correction. But he's done really, really well. So, and you can actually, I've done a lot of cataract surgery after Intacs. This is so much easier to see through. I still use trypan, and I think, you know, one of the things that we had talked to Bernie and the Cornea Gen team is that, and that might be one of the things to talk about at you know, a future time. Some of the tips, the surgical tips, like Liz mentioned, and, you know, because I think there's a lot more to learn from that. But cataract surgery after Intacs and after CTAK is a little bit more challenging to see your capsulorhexis. I use trypan in the group of patients because you can see better. Some variety of different things like that. But it's not, you're not going to do it to then be able to put in a presbyopic IOL on that patient afterwards.
Well, there's a few more questions here, but I think I'll end on one more here, and a lot more around complications. And procedure appears fairly straightforward. What issues do you run into, or what complications can one expect or anticipate with these procedures?
Liz is an amazing surgeon, so she never has any kind of complications. So, but we had fellows, so we get to watch our fellows do cases. We can always blame all of our complications on our fellows, but I mean, I think so a couple things: decentration, critical to watch for. Post-refractive, post-LASIK patients, watch for that flap interface. So you go down over rather than, you know, it's not an airplane landing. It's like you're intubating a nasolacrimal system. So you go down over, you want to go deeper. You don't want to lift up too much on the tissue, especially in a post-refractive patient. I've torn the incision before and had to shorten my segment. You know, there's a learning curve to it, but in comparison to some of the other learning curves that you go through as a corneal surgeon or a cataract surgeon, I mean, they're learnable. I don't know, Liz, what other ones have you?
You know, sometimes like inserting through the channel, I've seen it, the tissue twist on itself or fold back, and just easier, just take it out and do it again. I mean, that's the nice thing. And I mean, and that's another thing, is it is removable. I mean, we didn't talk about that. Is like, let's say you did it in somebody and they got a bad result. Well, you can take it out. So that's nice.
Mm-hmm.
But yeah, so it can sometimes twist, sometimes, I mean, and again, this might be good for surgical pearls. webinar, you know, how to graft. It's slippery tissue. I haven't had this happen, but I've had some situations where I didn't think the tissue, that we lost the tissue because it's so clear and comes in clear fluid. And yeah, how to grasp it, because it can be kind of slippery to go into the channel, make certain so it doesn't fold backward or twist over. I think those are really the main things.
And you brought up a great point of that it can be removed. Have you had to remove any of your 100 cases?
Yeah.
I haven't. So I will comment that one of my previous fellows is watching tonight, and he said not all fellows have complications, which is true. But you know, but I would say that in my learning curve, my percentage was probably the same as our fellows. So, so it was certainly, I can say I misspoke. So wonderful fellows. So.
Excellent. Well, thank you both so much for sharing your vast experience in this very young procedure that we know is going to explode out there. So much interest in it, and you guys are the leaders in volume and have the largest set. And so far, and I know you continue to do that as well as your colleagues. So thank you very much for sharing your expertise. It was awesome. I also want to say thank you for all of you that stayed here a little bit longer with us and participating, and thanks for all the questions. We didn't get to them all, but we did get to the majority of them, at least the majority of the topics. And hope you enjoy the rest of your evenings wherever you are. Thank you so much.